Welcome everybody to the My Community Dental Center webinar on dental care. Today's topic is how dental care claimed its relevance during COVID. We know that COVID had a lot of unintended consequences and forced organizations, whether it's nonprofits or businesses or corporations, to not just pivot, but to adapt to what was going on with the pandemic. Dental care was no different. A lot of things happened. Dental offices were forced to close, and there was a special attention being paid to the importance of dental care as to how it impacted overall health and potential connection to COVID and its effects. So let's get started. Everyone okay with that?
Absolutely.
All right. The format is very simple. I'm going to introduce our three panelists. There will be a question and answers section at the very end. And however, in the meantime, there is, for everyone that's on right now, there is a Q&A section icon in your screen. There should be. Feel free to throw any questions out at any point about what you're hearing and some of the issues we're talking about. The way this will work is I'm going to introduce a panelist. Each one of them will have respective questions they will be addressing. And then after that, we will ask questions generally, which means any one of them can answer any of those questions, after which we will have a formal Q&A. So if everyone's ready, I'm going to introduce the panelists. You guys all set?
Yes.
All right. We have with us Tamar Shrikian. I think I got that right, doctor. You're a dentist with My Community Dental Centers, and you're based out of Charlotte, which is a mid-Michigan area. Welcome.
Yep.
We have Chris Farrell, Oral Health Director with the Michigan Department of Health and Human Services, who has been in the industry, if I can call it that. Chris, I'm sorry, I don't mean to embarrass you, over 30 years. Does that sound about right?
Yes.
A passion for it, someone that I've known for many years and is doing great things in dental care. And Eric Steer, Director of Quality Assurance, Utilization and Population Health Management for Delta Dental Plan of Michigan, Indiana, and Ohio, based out of Okemos, which is also mid-Michigan. Eric, welcome to the panel.
Thank you.
So thank you. We're going to start off with Dr. Shrikian. Dr. Shrikian, what do you see? What was it that changed during the shutdown? What did COVID do? What were the barriers to, to dental care in general? What was it that we saw? I mean, it seems so obvious, but share with us what you saw in your capacity.
A better question is like, what didn't change? Because everything changed. I remember it vividly. March 16th, we got an email from the CEO of MCDC that said that we would no longer be providing typical dental care and that we would be transferring to emergency only dental treatment. We ended up, the company, MCDC, ended up closing about 20 of the centers temporarily for 3 whole months. And then the remaining centers that did stay open, Charlotte was one of them, had a skeleton crew of 1 assistant, 1 front desk staff member, and 1 dentist. We only provided emergency care for patients we were planning on doing it until April 3rd, 2020, which seems laughable now. And we ended up providing solely emergency care until June 16th, I want to say. So 3 entire months of emergency only care for our patients. We had challenges with personal protective equipment. We had to ration those and be cautious about those. And I think that there were many nationwide stories regarding that. We had to, I ended up doing a lot of teledentistry calls for patients that were not able to come in, either due to concerns about personal health or even distance, because we were seeing patients from statewide that were calling us and trying to just have some access to care, because MCDC kept their phone lines open, whereas a lot of private practice offices weren't able to do that because of staffing concerns and unemployment issues and things of that nature. So it was a wild time.
Sure. So I'm wondering, obviously, the number of calls I would imagine that you were receiving because of this increased over time. And I'm wondering,
For sure.
you know, how did you deal with that? I mean, that's a tough question, but how did you address that? Because you were
Well,
getting calls from people that normally may not call MCDC, is that correct?
that's absolutely correct, Raul. We had a lot of patients that were not patients of record for MCDC, and they were just like they were grasping at straws, reaching for anywhere that would be able to help them. So a lot of people were calling us. We initially, there were days where we would see one or two patients right at the beginning in March. But by June, we had a packed schedule where we were only seeing one patient at a time, but we were like trying to be as fast as possible to see the patient, turn over the room, conduct our new, sanitation protocols, and, just like really like make sure that everything is clean, and then get the next patient in so that we could, triage the issue, take care of the emergency if needed, and then discharge them to be able to see the next patient. So we were, we went from seeing, maybe one or two patients for emergencies per day to probably seeing more like 15 to 20, and that's not even including phone calls we were fielding. So
I'm wondering, you mentioned the telemedicine type of approach you had to deal with. What do you see now? I mean, did that kind of set a new standard for what you're doing with that? I'm just curious.
Yes.
With regards to, is this something, a new approach type of thing, or?
it was a bit of a new approach. We kind of, we were taking it in, we were kind of experimenting with the medium, as it were. So we had to create standards for what types of patients would be eligible for a teledentistry appointment. In those cases, we determined that patients that were of record, that we had x-rays on, and that we had seen within the past year, would be eligible for a potential teledentistry appointment. And then I would find time in my, day, I'd call them, try to figure out what the issue was. And then, after doing that, then I would have to, take different notations to, provide appropriate documentation to say, talked to the patient over the phone. This is what we, deduce based on talking to the patient and looking at their already existing x-rays and trying to piece together what it was that was going on, but then also encourage the patient to, after figuring out what was going on, probably calling in a prescription, to then follow up with their typical MCDC office, if that was us or if that was another location. So
Just quick follow-up. I'm wondering, was that one of those unintended consequences now that you're looking at the telemedicine as maybe this is something that we never really did, that was not as prevalent, that maybe we can adopt? I guess that was part of my question. I'm curious if maybe that was one of the consequences of all of this.
It's a tricky thing, because ultimately to do dentistry in reality, it does have to be done in person. But I do think that for emergency situations, or for issues where there is access to care concerns, either patients disabled and unable to leave their home, things like that, it can be used in select circumstances. And we've definitely used it more even coming out of the pandemic because of that. So.
Great. Well, thank you. That was a great start to the discussion. We're gonna come hang out with you, Chris, now for a minute or two. You're gonna talk a little bit about oral, about oral health as an essential benefit. Chris, dating back to when you and I worked together many years ago, sometimes there's this misconception that dental care might be considered more of an aesthetic or maybe a cosmetic type of thing. And I'm wondering, how did the conversation change during COVID about oral health? And in particular, if why wasn't it part of the discussion during COVID? And how did it get to be a discussion during COVID?
Um, well, I've been thinking about this also because, as you mentioned it about, oral health and what was the impact of COVID, and actually listened to Dr. Shrikian also. It's like, okay, where were we a year ago, 15 months ago? And a lot has happened. And I had to think about that, about why weren't we, why wasn't really oral health part of the original COVID conversation? And I think it does go back to, but you kind of alluded to it too. It's like there has been a medical dental disconnect for a number of years. I mean, we're working on it. We're trying to talk about medical dental integration and how the impact of oral health is on so many different health diagnoses, the diabetes, asthma, heart disease. But I think at this point in time, when COVID's, we didn't really know enough about COVID, and it impacted the hospital systems, the health systems. And dentistry is not necessarily part of a health system, a hospital health system. So you're seeing all, people getting sick going to a health system, not necessarily the dentist. And so they're trying to get care. And then the public health system, and that's another drawback.
Can I interrupt you for a second? Why is that? You made a really critical point about that. Why is that it wasn't always seen as part of the overall health?
I think it goes, I think both maybe Dr. Shrikian and Dr. Steyer can mention it too, but I think in just overall and in just history talks about, and back in the early 1800s from where it started, is that medical and dentistry, kind of separated, and dentistry went on to be, dental schools, and how dentistry became its own profession. But there, and there really hasn't been a good connection between medicine and dentistry for a number of years. But I will say that over the last 10, 15, maybe 20 years, there have been groups that have been really trying to integrate medicine and dentistry a lot closer, so that we can talk to each other. I think you probably talk to many medical health or any kind of health professionals. It's, pretty much a lot of times health professionals were kind of siloed. So I'd say that, for health systems, dentistry hasn't been part of it. And we're, that's one of the things we're looking at about is emergency department care, and how do we work with emergency departments that, people coming in with tooth issues, how do we get them into proper dental care? But a year ago, I think with COVID, I think it was just that the hospitals were overwhelmed. They were trying to treat patients with this new disease, and it wasn't like they were really looking at partners. Who could help me? Where, how do I, what's oral health? And I think you're going to hear a lot from a lot of different health professionals about other care that was put aside during this time. And that unfortunately, oral health and dental decay doesn't wait, and that we are seeing that we're probably going to be seeing the increase of dental decay in a lot of people over the course of, the next year or so, because dental decay can get bigger, can cause abscesses, can cause other issues. And so hopefully, we can start treating them. And I think what you saw with Dr. Shrikian saying, we started out only seeing 1 or 2 emergency patients, but by 3 months later, we were seeing a lot of people because they had put off their care. And one of the things that we did do here from the state is look at, I, as the oral health director for the Michigan Department of Health and Human Services, I work with a lot of safety net providers. MCDC is one of them. Michigan Primary Care Association, which handles a lot of the FQHCs across the state, the dental schools, and the MDA. We came together and had some meetings. And one of the things that we developed was a safety net directory for COVID, for people, that were, places that were open during COVID. As dental offices closed, we had to make sure that there was a directory that we posted on our the MDHHS oral health webpage so that people could find a dental office that was open. And I also think that, why weren't we also part of the conversation? I think that we were part of the conversation in terms of helping. I will tell you that in terms of the PPE shortages, you heard about that for the hospitals. Many dental offices, while they were closed, donated so much of their PPE, their masks, their gloves, because I don't think people realize that dental offices have been practicing infection control for almost 30 years or more than 30 years. It started with the HIV epidemic. So we've been wearing masks. We've been wearing gloves. We've been sanitizing dental offices. So we had a supply, and then we were offering, those to hospitals and other, areas that were, that needed it. So it wasn't that we weren't part of the conversation. We were indirectly helping out by, behind the scenes, helping out that way.
I'm going to ask this question, and again, we encourage questions throughout this. And Chris, this is directed at you. Andrea from Channel 13 in Grand Rapids asked this question based on a comment you made, Chris. Can you quantify or estimate how much the demand for emergency services increased? Chris mentioned it was 2 to 3 people getting emergency services. How much did that go up? How much of an increase did we see, I think is what she's getting at.
I don't have that data available. I will tell you that there is data available in terms of, especially through the American Dental Association and their Health Policy Institute. They've been tracking data over this last year, and they will tell you when they saw this huge decline between March and June of dental offices closing and productivity and different things. We have not looked directly at emergency care and how, what kind of impact that was. I'd have to see what ADI, the Health Policy Institute, if they have any data, but I specifically don't have it, or the oral health program doesn't.
Safe to say that there was an increase.
Yes.
Yeah. Okay.
And I think, yeah.
Okay, Chris, the last question I have for you is, and I'm going to preface it with this statement. Anytime we go for a checkup with our family practitioner, they check everything, including the eyes. And if they see something abnormal, they obviously are not trained as ophthalmologists. Having done work with ophthalmologists before, they relied a lot on referrals from either optometrists or family practitioners that saw something wrong. What needs to happen to continue making sure that the same attention is being paid to dental care or dentistry?
I think there's a lot that's happening over the last few years. And before I get to that, I want to talk about teledentistry. It's not telemedicine, Raul. We call it teledentistry, or you might call it telehealth. That encompasses everything. But I think teledentistry is part, I think you said is unintended consequence, is one of the pieces that we are hearing, and that I think it is here to stay. And how will it be incorporated into how, dentistry overall? And I think that is one, and I think it's a great thing that we can incorporate, because the demand for care, and if people can't get into care, teledentistry might be able to triage and determine who can get into care. Because Dr. Srikan says, you have to be, really dental care is provided in the chair. It's not necessarily, but maybe over the computer or a phone, but we can triage folks. But I think what you're going to be seeing is, and I think there's a lot of discussions around trying to the medical dental integration, trying to get, we already seen it in some of the FQHCs where we're incorporating hygienists, dental hygienists to do preventive oral health visits with pregnant women. We have a lot of, with our Varnish Michigan program, a lot of partners with pediatricians, family practitioners. We've been working with WIC nurses on, young children 0 to age 2 to get in talking to families, talking to them about early visits and putting on preventive fluoride varnish. We've been working with community health workers to talk about oral health modules so that when they talk to their, clients, about dental care, I think there's, the sky's the limit in terms of looking at, in the diabetes programs to talk about an oral health, educator coming to talk in those, the diabetes programs. Cancer, I've listened to some beautiful and great webinars during this last year about cancer units having a dental person to do, triage and look at, for cancer patients, the impact on their oral health for, especially the drugs or the afterwards, their aftercare, the transplant patients. Even there's, been some great studies that, Sparrow Hospital has put out about trying to incorporate oral health care for those patients and decrease those, all of a sudden my mind went blank, hospital acquired pneumonia, so that the patients, don't come back in with some kind of, some pneumonia that could be attributed to their oral health care. So I think there's plenty of medical dental integration ideas. It's a matter of, resources, funding, some of it's scope of practice issues, so, but I think things will slowly change, over the next few years.
Great, thanks, Chris. Eric.
Yes, sir.
Now we get to pick on you, Eric.
That's all right.
The everything we talked about so far also has an impact on not just the demand, but also access. So I want to talk a little bit about the equity and access with regards to dental care and dentistry. There's so many conversations, regarding the issue of equity. How does equity, or how does that fit into dentistry and dental care?
Well, I think the first thing we have to realize is that in the integration of medicine and dentistry and putting dentistry on an equal foundation or footing as the medical health sciences is very important. And that's the integration that's happening that Chris is speaking about. Most of us, we certainly are in our group, are working with a variety of engaged stakeholders and mission-aligned entities, organizations to promote the importance of oral health, including addressing the disparities in oral health and oral health access in the variety of communities that we serve. And going from, the most important part is going from an administration of benefits to a system based on population health management allows us to start addressing this issue of access. So imagine 1 million children, suffering from a variety of issues related to poverty, and then complicated by individual factors that we collectively call the social determinants of health and or demographics, where we analyze such issues along with patient demographics, utilization, and the overall number of providers available to start developing outreach scenarios and projects, and then implementing and evaluating as we go along for success. But it goes so far beyond location, language, culture, ethnicity, skin color, whatever the issues may be. The point is that there are vulnerable children, and in our population health management efforts, instead of just administering benefits, we're seeking those thoughtful interventions to assure an equitable access. Part of that is not just the hard data that I'm mentioning, the demographics, the information available from state and federal resources. It's the integration that you were speaking about earlier. At Delta Dental, we engage with a variety of organizations, from patient advocacy groups, grassroots, to a clinical-based safety net clinics, provider panels, health systems, to address this issue and raise concerns that they may know better than we do. And then that's integrated into a system of evaluation to prioritize outreach to address issues of why people are not receiving the care that they need. It becomes a purpose-driven, individual-focused, but community-centric type of outreach that includes the providers. It's not just recognizing the barriers to care that people are suffering from because of poverty, location, or other issues. It may be issues related to the providers themselves or the entities that they work for. What barriers are they facing as related to reimbursement and or difficulties with patient truancy, and then trying to assist them. And then this is, at Delta Dental at least, we constantly monitor and monthly segment our population based on patient demographics, available other sources of information such as medical information, social determinants of health. And then we try to integrate that into action that we constantly evaluate, modify, and correct as we go along. And part of that is, what are the services they're receiving? We're not content with just seeing that children receive services. We want to make sure that they're quality. So it's a very complex system of population health management, quality assessment, and utilization management to assure their quality services.
Well, and I'm wondering if I can ask this. So I imagine one of the challenging areas would be in the rural areas. And I'm wondering what role dental professionals or organizations like yours or any dental care organizations, what role do they play in trying to make sure that those individuals have access to it?
In our case, a very large one. And first things, like, as I mentioned, Raul, first you recognize the expertise in communities where you need to be involved. So whether it's a health plan we're involved with or a health department, we work with them and support their existing efforts. A good example would be the Community Connections program in northern Lower Michigan that draws together a variety of data sources, including those that are provided through iPads in dental clinics and or other ways, that goes back to a social worker who then facilitates care. Or it may be the support of a mobile outreach program. As Chris mentioned earlier, the SEAL Michigan, the Smiles on Wheels efforts, were very large supporters of that activity. And it's not just financial. We'll provide resources, care coordination, and also a text-based outreach system that makes people aware of the services coming to their communities. And we're talking about dozens of school districts in the Upper Peninsula, Northern, Lower, and Central. Or it may be a safety net clinic or excellent dental centers such as My Community Dental Centers, where we collaborate on collaborative messaging and that goes out in a text-based format to make people aware of their benefits. They may not know. To educate them on the importance and the integration of medical, dental, and medical health, and why your oral health is absolutely essential to your overall health. Such as, and they share common risk factors. And then we empower them to make the decisions and then provide them the resources to find the dental center nearest them, whether it may be MCDC or another setting. So it's a constant system working with partners to provide that service.
That leads me to the question I want to ask. I want to comment first on going back to confirming the whole issue of dental care, and when you go to the doctor and they check your eyes, but they don't check your oral health. It's interesting that in my case, especially, and it's not the first time, when I was offered health coverage through my company, there was a vision rider attached to it, but I had to ask about the dental care part of it. It seems like that's always the case. Not the first time I've had to do that. So, but let me get back to, you mentioned talking about partners. What has happened in the last year with COVID, I would imagine one of the other ways to adapt or, to address what's going on, I would imagine is you almost had to rely on partnerships in order to start addressing some of this. So I'm going to throw this out to, I'm going to go with you, Dr. Shriki, and what you've seen with MCDC with something like this. you were almost forced to collaborate and form these partnerships.
Oh, absolutely. I mean, I don't think that we would have been able to do half of what we did or reach out to half of as many people as we did if we hadn't had help from organizations that were larger than MCDC in certain ways. Whether it was, posting on MDHHS's website about the fact that MCDC was a dental provider that was staying open, or if it was using Delta Dental's platform to, let them know about our services and, how we can provide them for folks and go from there. I mean, yeah, it's critical.
So, Chris, let me go back to you real quick. From the state side in your work, what did oh, I mean, let me ask this of all of you. Where do we go from here? I mean, we know there's the issue of there needs to be more attention paid to dental care and oral health. We know that we can't do it without partners. We know that there's an equity and access issue. Who do we need to bring into all of this to make sure we're addressing all these issues? Understanding there might be elected officials on this webinar. I just say that for full transparency, but where do we go from here? What needs to happen? Right now that we know this is such a critical issue, right? More so than pre-COVID.
And Chris, you're muted right now. I can see you speaking.
I do that all the time. Sorry. I know that's the new phrase. You're
right. Yeah.
I think, we are in the process of working with the Michigan Oral Health Coalition, and they are, they're really the voice trying to pull in all kinds of different partners. And, besides just, we need partners beyond the medical community, the dental community, human services. We need business, we need academics, and we need, policymakers and advocates, anybody interested really in that oral health coalition. We have a statewide oral health coalition, and there actually are some regional local coalitions. And if Andrea is still on the call, there's the Kent County, there's a Kent County Oral Health Coalition. Western Michigan, that's pretty active. And they have some wonderful data too. I'll throw that out there. And I can give you their contact information later. But anyways, I think and then we're looking at a state oral health plan. And we're looking at our new 2025 state oral health plan that we have been working on this past year with the Oral Health Coalition to talk about, where do we go from here and what's needed in addressing that oral health equity issue as, kind of an overarching goal, and, what are some of the principles about, medical dental integration, access to care, how do we get people into care? And I think a lot of it is a raising it's prevention and awareness. So, I think there are groups, we just need to expand that group. And I think, we all tend to look at partners, that we have to look at non-traditional partners. And I think that's where the business community comes in, or, some other group.
I'm curious, and Eric, you work with a lot of different groups at Delta Dental. So I'm wondering, and Dr. Shrikian, please feel free to jump in as well, but you keep bringing up the business community, and I'm wondering if you could qualify that a little bit. What role can they play?
Well, I can, speaking from those businesses that are certainly involved in healthcare to start with, because there's a lot of opportunity for collaboration and sharing of data, if allowed, if permitted, that can be shared to promote health, overall health, through collaboration with dental initiatives. So as I mentioned earlier, there the shared common risk factors for the most common causes of non-communicable death, such as diabetes, cardiovascular disease, respiratory disease, and cancer, all share risk factors with dentistry, with dental risk factors such as periodontal disease and caries. such as smoking, high sugar diet, obesity, and the like. And there's a lot of opportunity between the health plan businesses and the dental benefit administrator businesses to conduct coordinated outreach, whether it be in support of diabetic patients, patients with cardiovascular disease, or those who use the emergency room for dental purposes. One of the barriers to care, if there are representatives on the telephone, is being able to access and share that data between plans. Quite often that's an issue. So if, and a good example was if a dental benefits administrator had available emergency department use in a very, very topical fashion the day after or a week within, you could conduct outreach. Delta Dental conducts care coordination outreach on a daily basis to facilitate care for people with special needs. But it would be a much more proactive approach if that data were more available. We're in constant discussions with our health plan partners who administer the health benefits, and we share patients. But it could be so much more if the data were more easily shared amongst ourselves to conduct that type of outreach, because it's a mutually supportive set of information. What will help the diabetes or control of diabetes would also help facilitate better oral health. And the correlation between the two mitigates problems back and forth for both disease states. So a very large issue is the ability to share information in support of health information integration. It's not as easy. There's a lot of requirements to support such initiatives, but then when it comes down to brass tacks to do it, it's quite often very difficult. So at this point, we do it, in our instance, we conduct it on a very local basis in conjunction with community groups, oral health coalitions, clinic infrastructure, and the like. But to be able to conduct that type of outreach proactively based on real-time medical information would be very helpful.
Well, if I'm not mistaken, I think I remember reading a study, maybe it might be about a decade old, but I think it's still pretty telling and pretty accurate. If I'm not mistaken, 20% of emergency room visits were dental care related. And I think that the price tag put on that, if you put a price tag on it, was just over $2 billion, in cost. And that's a staggering amount when you think about it. I'm not so sure that I don't know how that has fluctuated since then. Last ADA study was done, but Dr. Shrikian, what do we need to do? I mean, Chris already, confirmed that, well, we don't have the exact numbers. There has been that spike during the last 14, 15 months during COVID. You've seen, obviously you've had to resort to teledentistry because you've seen that much of an increase. What can you add to this discussion on what needs to happen? I mean, that's a staggering number of people going through an ER for something that could have been prevented.
So what's an interesting outcome of the pandemic is that I've noticed is I've had some patients that I've seen that they're like, hi, it's nice to meet you. This is my first time coming in. Now that we're back to dental care as previously, scheduled. I've had patients who I'm seeing for the first time, and I'm asking them, when was the last time that you went and saw a dentist? Oh, it was 10 years ago, the last time that I had dental insurance. And an interesting outcome of the pandemic has been, in my opinion, is that people in certain situations, because of unemployment or because of, hardships and things of that nature, they've been able to qualify for Healthy Michigan plans, either service through Delta Dental or other servicers. And they've been able to actually get the care that they need because, that's such a huge part of it. I also think that there's an element of education on a patient level too, because I've had patients that have had Medicaid for a long period of time and then didn't understand or didn't realize that dentistry was a portion of their Medicaid services that were going to be covered. So I think that, like, on a small level, it can be patient education related, but to echo what Chris had been saying about the idea for a statewide oral health plan, I think that would be revolutionary. I think that would be so critical. I think it would be an excellent way to integrate the gulf that there is between medical services and dental services, because I think that people understand and recognize that, you know, if you have an emergency, you go to the emergency room. But I don't think that people understand that dentistry and having a dental emergency or having, you know, periodontal disease is just as critical to treat, and not in a chronic fashion, in an acute fashion, you know.
Right.
And I'm sorry, to add to that, to complement what Tamar just said, is that early education, a big part of what most of us are doing is an early screening and risk assessment. So when somebody is new to the program, they will receive an offer for a screening and risk assessment, and it's developing into a much more agile two-way sort of communication here at Delta, where one of the issue, or several of the issues that we've been talking about, whether it's the use of the emergency department, and or if you have chronic health issues or other barriers to care, that's given to newly eligible patients in a proactive fashion to start that educational process that Tamar's talking about. And that's absolutely correct, because we're being reactive, much like we are with teledentistry. And there's a proposal that's going to be coming out of my chair shortly about being much more proactive, not only in the educational opportunities, but in services such as teledentistry. And an example of that is ongoing phone outreach or text-based messaging. It gives the opportunity to the patients to identify their barriers to care, their special needs, but also upfront educational resources related to the proper use of the emergency department and why it's important to take care of, get to a child to a dentist at age 1 and thereafter follow a schedule, the periodicity schedule, but also relating the responsibility to the caregivers that what's going on in your mouth in your world is affecting your children, and you can make a difference right now by getting them in early and often. And MCDC has been a great partner in that. I know we've done some continuing education with them, but it was preaching to the choir. They were already doing it. Spreading that message, we have thousands and thousands of providers, but having people who are committed to the procedure is a big part of what we do as well. That type of support for the provider panel, because without the providers, we have nothing. And so besides easing up the sharing of important data between health plans and dental plans, that's one issue, but also realizing that the burdens and the requirements that you place on the provider and the panels in general might tend to drive them away rather than draw them in. And that's why there are a variety of value-based payment programs to try and entice them to be part of it.
You just brought up, and I was going to touch on that, Eric, especially with MCDC, Dr. Shrikian, you're a mission-driven organization, if I can, simply put, but just based on what Eric just said, what barriers are you seeing? I mean, there continues to be a shortage in dentists to provide the access you need through MCDC, statewide, especially, in the last year during COVID. But I'm wondering, are there barriers that need to be taken a look at, and what can be done to bring some of those, they're still doing dentistry and it's a little more mission driven, but what kind of barriers are there? What needs to happen to attract more of these professionals to do this kind of work? $1 million question, maybe the $2 million question.
And you just answered it with your $1 million part.
Is that what it is?
Yeah, that's really, that's a big portion of it. I am so thankful that not only where I work is something that aligns with my personal values, but that it also has the benefits of having access to grants for people with student loans, like the Public Service Loan Forgiveness grant, and in addition to like more targeted grants that you can qualify for based on your center's score and things of that nature. But that's a big part of it. I don't think that people know about them as much, and I think that that type of education would be important. But I think that what Eric's saying is really accurate. I mean, there's a lot of private practice professionals that would, I think, do more work to increase access to care for patients if they, you know, were incentivized to do so based on, like, you know, compensation rates. I see that complaint a lot. That, you know, oh, like, it'd be so great to, you know, help patients that have Healthy Michigan plans, but, you know, we just don't get paid enough, you know, type of thing. So it's, I understand the complaint, and I've seen it from other professionals before, but yeah, and I think you're.
Well, a good story to emphasize that from both
Yes.
sides. The barriers to care that a person on the HKD program or similar Medicaid program, they may have several children, and they may have several reasons why it makes it very difficult for them to get to the dental office. So they may want to have all 3, 4, 5, 6, 7 kids bring in at the same time. Then one of those issues related to their environment, those social determinants of health we spoke about, raises up, and they no-show. And then a young practitioner such as Tamar, who's $400,000 or $500,000 in debt minimum, has a tremendous amount of open chair time. And so there are difficulties across the spectrum, from the people being able to access the care they need for whatever barriers in life they may have, to how much responsibility do we put on the provider who is struggling to pay bills, to possibly suffer from truancy issues and therefore the inability to make money. So it's a very difficult question, and sometimes in my mind it relates to the possibility of where the services are provided when the children are there. You know, take the mountain to Muhammad once again type of scenario, whether it's through mobile or community or school programs, through a committed organization such as MTDC or the like, any of the excellent FQHCs we work with, you know, in several private offices. There are several people who are willing and do it. But I think for the community and policymakers in particular to understand is there are no simple solutions, but the conversation has to continue to address that early prevention, because if we keep going the route we are, we'll continue to pay for more expensive services on and on. It has to start with changes in early intervention and education, and then incentivizing providers to be part of it, because quite often the providers are the ones who suffer the most when trying to do the right thing, because of patients, through no fault of their own, a lot of times inability to make that appointment. So very difficult question, but that's why education, empowerment, and self-responsibility are such important issues to address.
Great, and that's a great segue for you, Chris, to add to that, please.
Yeah, and I will take the other side, is that in terms of Eric mentioned going the mountain, going to Muhammad, and I think that's what we are trying to do, is we are trying to address and meet people where, you know, where they're at and what their needs are. And there are a lot of increased school programs, the school-based health centers, our Seal Michigan program, which provides sealants programs in schools, or going to Head Starts, trying to address, or going to homeless centers, bringing the dental care to those clients. And so that there is, you know, trying to address that all of those social determinants of health might be that we go to them and provide, you know, bring the care to them. And, you know, so that we can go to their homes, go to their schools, go to their, the migrant sites, go to, so where they're at. So they aren't, you know, if they have transportation issues, childcare issues, that we're meeting those families and where they're at. So trying to make it easier for them and you know, bringing the care to them. But it, you know, it does take resources. It takes commitment, and there are plenty of committed providers who are willing to do that and go out into those centers. We have quite a few mobile dental providers across the state who are willing, you know, that work with the those patients, and I think that is, I think, as you mentioned, what COVID has, it has shown like the disparities and the inequities, you know, not just like in the vaccinations and in the testing, but in the oral health care. You know, where do people get care, and how can we address it? And, you know, we are trying to look at bringing that care to those communities and where they need. And again, that's what maybe teledentistry will fit in for some of those rural care, you know, that rural care. And we, you know, try to figure out, oh, you need, you know, where can you get care, and, you know, where do I find care? So I think there's a lot to go on. And I also think that there's also that cultural competency that we've heard about, that we also have to address. You know, what does, you know, where's the education and the, you know, the knowledge for patients, but also then for providers to understand where their patients are coming from and what their needs are. So it's like Eric said, it's not an easy fix. It's, you know, there are a lot of things we have to address. Won't happen overnight, but I think if we have some commitments, and like I said, I think that state oral health plan has addressed, you know, has brought some of those questions up and objectives, like how do we move this forward, and try to address some of those difficult questions.
Well, but I think this discussion is a great start to that. I think we can, you know, as I'm listening to this, there's three words that come to mind that in my mind kind of summarize what we're talking about: prevention, partnerships, and access. Mm-hmm. And there's a lot in there, but we are closing in on our time. Dr. Shrikian, Eric, and Chris, thank you for your time. We appreciate your knowledge, your insight. A lot of work to be done, but we know now that dental care is much more so than it was pre-COVID in the forefront. And it's a matter of doing everything that we talked about here. How do we address it? How do we form the partnerships to do it? What needs to happen with policy? And how do we make sure people have access to it?
Yep.
Again, there's a lot of unintended consequences. We've seen them. We've addressed some of them. 5 seconds to each one. Any last words? Dr. Shrikian.
I mean, change is constant, so
I love that.
We just have to be the next step.
Thank you. Eric.
Find a community, listen, engage, and empower them, and work with them to support that community based on whatever needs they have, whether it's cultural, language, or whatever barrier to care. So just work with the community and listen first, talk second.
Love it. Chris.
And I will be about promotion of oral health to everyone, and look for our new our 2025 Michigan State Oral Health Plan that will be released through the Michigan Oral Health Coalition at the end of the month, of this month.
And we'll look for that information from you, Chris. Again, thank you to all of you. Thank you for everyone that joined us on this important conversation. This will continue, so stay tuned. In the meantime, have a great evening, and let's keep doing what we need to do.
Thank you.
Thank you, guys.
For the opportunity.
Thank you.
Thank you.
Take care.
Bye.
Thank you.
Bye.